All right, so next thing we're going to talk about is, I know this is probably going to seem boring, but it is kind of important stuff, is on the taking vital sign and baseline vital sign. One of the things that we're going to revisit is lung sounds and the importance of those and what those sound like and some of the indications of that. So we're going to kind of work through this. On the vital sign side, what do you guys consider baseline vital signs? So baseline, what vitals do you take a list? Every single patient you encounter, the list. I don't want like, well, sometimes I check this. Every single patient, what is the group of vitals that you take on the initial assessment? Pulse, blood pressure, respirations, glucose, SPO. That about it? Right? Anybody else add anything else in there? What about temperature? Maybe, right? Could you? Yeah. Sure. I mean, not rectally, that gets weird. For sure, don't rectally thermometer and be like, oh, that's the wrong one. Yeah. Pulse, respirations, skin color, temperature, condition, that one just kind of thrown in there. Pupils, right? Blood pressure. Now, the interesting thing about the glucose is getting a glucose a vital sign, or is it considered to be a procedure? It's considered to be a procedure, which is why most books don't call it a vital sign, right? And especially in the NREMT side, there are still states, I think, I'm not sure for sure, but that wouldn't allow EMTs to take a glucose. You could give oral glucose, but you couldn't check their sugar before, right? That made a lot of sense.
They just allowed glucose in Idaho.
In Idaho, yeah, I wasn't going to pick on them because you were from there, but I couldn't remember if they still were that way or if they allowed it.
They
finally allowed it. Look at Idaho coming with the times.
Well, intermediate's advanced with it, but
right.
That's for basic people.
Yeah, because you're just basics. But that's kind of the idea, right? Now, obviously, baseline vital signs are the ones that you very first obtain on your assessment. Follow-up, right, is going to be those repeat vital signs. What's interesting is I always ask providers, like, what's the purpose of baseline vital signs? What does baseline vital signs tell you about your patient? It's not nearly as much. It's a starting. I always say, are they alive? Are they dead? Right? Your second set of vitals just barely breaks the ice of starting to tell you what's wrong with them. In my opinion, it takes that third set to be like, all right, where are we at? Sick, not sick, getting better, getting worse, where are we going? Okay? Pulse rate wise, kind of a reminder, normal heart rate for an adult is what to what? 60 to 100. Anything less than 60, you can read based on. Anything less than 60 is going to be bradycardic. Anything more than 100 is going to be tachycardic. Right? The things to remember is counting is easy for most of us, right? Count for 30 seconds, times it by 2, or let's get real, most of us just use the SpO2, right? But checking a manual heart rate is important. Now, even if that's just check a radial pulse and getting a rhythm and a quality, I'm on board with that. But don't forget that you learned in your EMT class that you're supposed to get a pulse and its rhythm and its quality. How many of us just look at the SpO2 or the EKG and go, heart rate's 100? Well, that's cool. The machine tells you heart rate's 100. But what if your heart rate was 100 and it was weak and thready? That changes your thought process. So don't forget, we rely a lot on our equipment and not so much on our patients. What do you got, right? Right. Yeah, well, it's just weak, like not very strong. They're strong and thready, and they're opposites. Make sense? So you almost can't feel it, right? Almost like it's just like a hum, and you're like, is that a pull? Yeah, kind of feel it there. You might check brachial or carotid and be like, okay, so they got a strong pulse. You go back to that radial and go, so it's just weak and kind of hard to feel. Okay, thank you. That's not a dumb question. Good question. 4, so that's it. Look at that. When pulse feels weak and thin, it's even red, right, for you, right? So that's that pulse, that pressure. Now, on the regularity side, this side, that rhythm, if you feel for a regular pulse, and what I always tell students, especially when they're new at this, that 30 seconds, start to get a beat in mind, right? So you're like, okay. And then when you don't feel it and it skips a beat, like, hey, you got your regular heartbeat? And most people that have it say, oh yeah, I've had it for a long time, right? All right, no big deal, right? Or you got the AFib patient, it's like dump, 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 and then there's the blip. Oh my God, I can't even count them. You got to count that entire minute, right? Those are the ones you stick your SpO2 on, and that SpO2 ranges, right? It says heart rate's 40, 80, 130, 10. You're like, oh my God. It's probably pretty typical, right? It's just trying to guesstimate their heart rate based on their current beat. Common pulse locations. Here's what's missed. I love this. Most EMT students do it. I don't see a lot of providers doing it as often. But if your patient's awake, a radial pulse is okay. If your patient's unconscious, a radial pulse is not okay. Go for a carotid. So if they're conscious, start with your radial. If they're unconscious, start with your carotid. Now, you could argue an unconscious patient, you check for a carotid, good, they've got a pulse, no CPR. And then check your radial to see about perfusion. But start with your central pulse first, okay? The other one is, I don't know why I still people see using their thumbs, or they're checking for a pulse on the pinky side. I always love EMT students that are checking for a pulse mid-forearm. They're like, it's 65. First off, how did you get the odd number? Second, that's not where you feel for a pulse, right? It's like the blood pressure. They come back, they take the blood pressure, they release the cuff all the way, and they look at the sphygmomatometer, and they go, 129 over 89. You're like, first off, I got 3 reasons why I know you're lying. 1, you shouldn't have to read the blood pressure cuff for 35 seconds after the fact. 2, there's no odd numbers. 3, take it again because you're lying, right? We're going to talk about that here in just a second. Brachial pulses. Under the age of 1, no radials, no carotids. Go for that brachial pulse. Okay? Look, it's a baby. Make sense? Carotid pulse. Again, check first in all unconscious patients. Okay? Respiratory rate side. Now, how many of you actually count respiratory rate? Yeah. For the recording, no one raised their hand. I want the court recording to show that nobody raised their hand. How many of you document respiratory rate on all your reports? Yeah. I want the court records to show that almost everyone agreed they're all liars. We look at people and go, I'm 12. Right? It's fast, must be like 20, right? If it's more than once every 3 seconds, we're going to call it like 26, right? It's so common for us to not count these. Now, why do we not count them? What's the reason? Time. What else? It's difficult to do, especially if that's not their problem. If they're breathing normally, I do the awkward thing where I touch their back, or I touch their chest, or you put your ear next to their chest. That gets really close and personal. Right? Especially you're going to take your shirt off and then you're embarrassed. It's just weird. Okay? It's like watching Frozen together. I don't know. It seems odd. Normal pulse rate, or respiratory rate for an adult, 12 to 20, right? Quite a range there. Anything below or above 24 is potentially serious. Anything less than 8 is potentially serious. Again, take your scene and put that all together and determine if it matches what we're talking about. Okay? 4 categories: normal, shallow, labored, and noisy. Now notice normal is a rate issue. Shallow is a tidal volume issue. Labored is usually an airway issue, as well as so is noisy. Okay? So a couple pieces thrown into that. Now, breathing pattern. How many of you know these breathing patterns? Right? A couple of them. Cheyne-Stokes. Where do we usually talk about that one? Head injuries. Nice work. Right? Kussmaul breathing. Where do we usually talk about that one? Hyperglycemia, right? Or on the diabetic ketoacidosis, that DKA side of things, right? Tachypnea, which is fast, right? Bradypnea, which would be slow, and then biots, right? Have you ever heard of biots? Heard of it, read it in a textbook once, never seen it. Okay? Now, here's what's interesting. That conference went to in Vegas. Ryan, you want to do something really fun? Sure. All right, just stand up from the room for a second. So, he did this with an individual. Let's see if it works with Ryan. So, stand right there. Don't move. I'm going to come catch you here in a second. So, we get the mix between breathing fast, tachypnea and hyperventilation mixed up. Make sense? So tachypnea, I want you to breathe, right, every 2 seconds. Make sense? So normal breaths, but just speed it up every 2 seconds. Go ahead. Okay? Now, he's going to breathe like this for the entire time I'm talking. Now, normal tidal volume, but just a fast rate. Does that make sense? Now, how long can he breathe like that without getting lightheaded? Tachypnea. What do you think? Are you even lightheaded yet?
Yeah, a little bit.
A little bit, but I mean not a lot, right? Can he go 2, 3, 4, 5, 6, 7 minutes? Sure. Now, go ahead and take some normal deep breaths. Good. All right. Now, what I want you to do is I'm going to have you take half the tidal volume, right? Half a breath and exhale hard. So you're going to go like that, right? Ready? Go. Now, how long till he gets lightheaded? Really quick, right? Like he's already getting lightheaded. You're going to stop. That's hyperventilation. They're not, you can sit down. They're not the same thing, right? Yeah. Right? The guy in Vegas, the person that actually started to fall, I was like, oh my God. Right? That's the difference. We're talking about a rate versus a volume. Tachypnea, not that big a deal. Hyperventilation, that's a big deal. Right? So don't forget the difference in those two things. Okay? Isn't that great? Do it yourself. You're like, holy crap. And just me telling you how to do it, I was like, it'd be embarrassing if I passed out. Respirations. We gotta stop making these up. Right? This one's funny to me. They said it was way funnier. Right? You read 600 crisis watching. Okay? Don't lie. Right? If you didn't check for it, then you could just underestimate. Appears normal. Right? Don't put a rate. That's honest. It appeared normal. Right? That's the nice thing about waveforms. They'll tell you a respiratory rate. Right? That's what we're going to talk about. So there's this idea of end-tidal CO2, or waveform capnography. And what it does is it measures your exhaled CO2. Now, anybody here use this besides Josh, so I know where he works? You guys have it? No? You should. That's right. You guys have it? No? You've probably seen this guy, but Alaska, pretty common. Probably in the healthcare, like in the hospital setting, without a doubt, right? Allie, up north. Yeah. All right. So what we're kind of talking about is a couple ways to do this. One, let's go pictures of it. No, that sucks. One way is there's a nasal cannula that hooks up to your oxygen as well as to your end-tidal CO2. Now, you don't want a lot of oxygen because it's going to mess with that reading, but you want them just inhaling and exhaling. And it measures your exhaled CO2. Now, on normal, we get a rate of 35 to 45, right? That's normal. Now, I think Doug talked about this with chest compressions. It also tells us how effective your chest compressions are. If it's less than 10, your chest compressor needs to switch. They're not doing a good job. Okay? It should be with good, solid chest compressions, and I mean like the best chest compressions ever. We're talking about we should be between 25 and 35. Lower than normal, that's okay. Right? What this does tell us, now since we pulled out the pulse check except for every couple of cycles, we can actually see the exact time return of spontaneous circulation occurs. Because all of a sudden, your saturations that are hanging out at that 25 to 35 range will spike, 60s, 70s, 80s. And that means all that CO2 that's been hanging out in your extremities that hasn't been getting perfusion is now circulating, you're exhaling it. And you can go, hey, wait, we got Ross, check a pulse. Okay, we can pick up on it a lot earlier. This allows us to BBM to maintain a CO2 that our body's used to. Okay? This is the other thing. So this is end-tidal CO2. It gives you a number. Waveform gives you a wave. When you inhale, when you exhale. Okay? So exhalation begins, and then inhalation begins. Now notice, when you inhale, your CO2 should fall. Right? When you exhale, your CO2 should rise. Now, a good normal breath produces this nice half-square plateau. That's normal. Everybody breathing right now should be looking just like that, except for Ryan, who's trying to compensate for all that CO2 he blew up. Okay? So here's the things that can tell you. If you got, let's say someone who's breathing fast, okay, or is hyperventilating. Look at their waveform, right? See how it still has a plateau, right? We've lowered the height of the wave because we're messing with CO2 levels, but for the most part, it stays nice and square. Now, would you agree that hyperventilation patients and asthma patients initially present the same, right? They're breathing fast, they're breathing heavy. Now, asthma patients need what drug? Albuterol. Does a hyperventilation patient need albuterol? No, it's just going to make the problems worse. Well, if they present the same, identically, right? 17-year-old female breaks up with her boyfriend and presents like hyperventilation. Okay? Same girl, no breakup with her boyfriend, but now she's got an asthma attack. They present identically. Well, with waveform, that's the way asthma presents. It presents like a shark fin. So now with end-tidal CO2, you can go, wait a second, this isn't anxiety. This is asthma. Because wouldn't you agree with an asthma attack, you can develop anxiety with that? If you can't frickin' breathe, your anxiety goes up. Well, one of them needs albuterol, and one of them doesn't. Okay? It can tell you if your ET tube becomes dislodged. Instantly, right now. Not like in 20 minutes when you're like, hey, we should listen for our lung sounds. Oh shit, there's no lung sounds. Right? Or you get to the hospital, and from the time you left your ambulance to the time you put them on an ER bed, the doctor, the first thing he's going to do is confirm your tube. And he goes, there's no lung sound, your tube's out. And you go, time out. We got waveform. It's been good for the last 45 minutes. It must have just come dislodged. Right? All kinds of stuff they can tell us about that. Your CPR, hyperventilation, hypoventilation, apnea, sedation, all those things that can tell us and confirm for us. Okay? Skin color, what does that tell us? Perfusion. Is that pretty important? I agree. Right? Pale, what are you lacking? Pale skin means you're lacking. Try again. Blood. Right? Cyanotic skin means you're lacking oxygen. Right? Jaundice, something's wrong with your liver. Lacking your liver. Drank too much the night before. Temperature. Right? What I love is all the pictures in the textbook of the person pulling their glove back and using the back of their hand on someone's forehead. How many of you ever worked in non-latex gloves before? What's the temperature inside your glove? Right. The surface of the sun. Yes. Right? And then you peel it back and you take your nasty, sweaty hand, you're sticking on someone's forehead. That's disgusting. Right? No. Stop it. Right? Why don't you use a thermometer? That's crazy. That's what they're there for. Pediatrics on the cap refill side, blood pressures are fairly inaccurate and under the age of about 3. Some people argue it's about the age of 6. Use cap refill. Right? Cap refill should be about 2 seconds. Pupils we talked about with the neurological, but don't forget to use these. In my opinion, if you don't have a pupil gauge that has the actual pupil, or if you don't have a pen light that has a pupil gauge on it, you really shouldn't be documenting the millimeter size of someone's pupils. Because unless you're that kind of a freak show that like memorizes that, I just want to put it next to their eyes, or like 2 pen lights, 2, 3, and 4. Right? When you shine a light in their eyes, their pupils should constrict. Right? Here's why they're big. I love it. People in car wrecks, right? July wrecks their car, pull out of the car, lay them on the sidewalk, cut all their clothes off, and put them on that nice hot sidewalk, right? And now we're treating them for hypothermia. And so now we start our assessment. And someone takes their pen light, shines it in their eyes, and goes, they're pinpoint, give them Narcan. Time out. Right? It's not a controlled, lighted environment. Right? So take the bill of your hat, take your hand, put it in the back of your friggin' ambulance, and get it to a controlled light, and then check their pupils. Right? Because when that giant ball of sun is beaming in your eyeballs, of course they're freaking pinpoint. Right? So be thinking about that kind of thing. Look for size, equal, reactive, right? Be aware that if they are pinpoint, right, be thinking about the presence of narcotics, okay? Especially in this day and age, okay? Blood pressure. How many of you really good at taking blood pressures? Me too. You put the cuff on their arm, you push the button that says automatic blood pressure cuff, and it inflates. That's kind of cool, right? Like Jay's like, oh, we don't have one of those. We gotta take it the old-fashioned way. We lie about it. Normal blood pressure, 120/80, right? How many of you ever had weird blood pressures? Right? You take it and you're like, well, that doesn't make sense. Which is funny is almost all the weird blood pressures I get come from my monitor. You look at that and go, that's like 60/40. Your patient's like, sure does. Guess what? It's not 60/40, right? Or it says 280/160. You're like, my God. Okay? So let's look at a couple of things that cause inaccurate blood pressures. The first one is a wrong-sized cuff, right? It's too big, it's too small. I love the ones that you put the blood pressure cuff on and you hit the monitor, and it pumps up and it tears the Velcro off and it falls off. So what do? You hold on to it so it can't tear off anymore. Why don't you get a bigger blood pressure cuff, right? Incorrect body position. How many have ever been to a doctor's office and the nurse yells at you because your feet are crossed? I always thought nurses were nuts, like incline your feet. Are you freaking kidding me? How does it mess with my blood pressure? It actually does, because the blood returning to your heart comes from your feet, right? Place the cuff correctly, right? I love watching different places blood pressure cuffs can be placed. You're like, where did you learn that? I did not know you could put it on the elbow. That's cool, right? So cuff should cover 2/3 of the upper arm to the elbow and the shoulder. The cuff belongs mid-heart level, and if you can help it, your patient belongs sitting up with their legs uncrossed, right? This is my other favorite. I love people who take blood pressures over big, giant sweatshirts. 120/80. Liar. First off, you didn't hear it, right? Second, I highly doubt they got perfect blood pressure underneath that Alaskan parka that they're wearing, right? Now, bearskin is the most accurate. I always have a base layer, something on ski patrol, we're always like, listen, let's get your coat off, let's get that stuff off. Your base layers, let's just try it over the base layer. I'm okay with that, right? Bearskin is the most accurate. I love this. Legs uncrossed, the patient is not talking. Come here, think. Shut up. Take your blood pressure. Okay? Now, I had an EMT class one time that said, who if your patient doesn't have any arms? That's why it says, what if they don't have any arms? Different places you can take a blood pressure. Yes, I know these are on the arms, but yes, you can take it on the leg as well. You just got to find a blood pressure cuff big enough to go on most adult human thighs. Okay? Maybe the ones that skip leg day, but that's totally different. Okay? So let's talk more about measuring a blood pressure. Okay? Yes. So, pulse pressure. How many of you measure pulse pressure in your blood pressures? Everyone's honest. Good thing. Okay? Normal pulse pressure, the difference between systolic and diastolic should be 40. Right? Anything wider than 60, increased cranial pressure. Anything narrower than 25 is shock. Now, here's when we started teaching this. Believe it or not, the NREMT got really tricky. And what they did is, on their test questions, they would give 18-year-old male involved in a car wreck, okay? High-speed collision, gets out, he's up walking around, says he's not injured. And his blood pressure is 90/62, right? Is your patient in shock? And most people are like, no, right? He's not injured, he's not complaining anything. An 18-year-old kid with blood pressure at 90, that's normal. What's not normal? The pulse pressure, right? We start to look at, wait a second, it's kind of narrow. Those are the things to think about. Use pulse pressures to determine wide versus narrow. Okay? Pediatric, again, younger than 3, really hard to obtain, so go ahead and use that cap refill. Temperature. Would you agree this could be a really, really good baseline vital? Yeah, right? Why not? What could you find with temperature? An infection, right? What if it's a bladder infection they didn't know they had? Now, you're not going to be like, go to temperature, it's a bladder infection. But you might be like, you know what? You get an elevated body temperature. Now, it could be time of day, activity, age, where it's measured. We don't do rectal temperatures in adults, okay? I love an advanced EMT class. There's protocols for rectal D50. No. Sorry, they have veins for a reason. Not in my job description. A nurse, maybe, but not in my job description. Remove that in the recording too. Oxygen saturation. Okay, we're going to measure that hemoglobin. Now, we all know this thing goes in the finger. Now, I'm a little bit old school for a couple reasons. I love the SpO2s that are attached to this giant boat anchor. Everyone's like, they're heavy. Yeah, but I don't lose these. The ones that just clip on the finger, I'm like, shit, I left it at the hospital. Right? You call the hospital like, hey, do you see our SpO2? And the nurse is like, oh, give it to me, it's in your pocket. Okay. Normal, we kind of talked about mild hypoxia. We already kind of talked about significant moderate hypoxia and then severe hypoxia. Accuracy of readings can be affected by all of these things, right? These things are great about measuring the number of trains that you have in your finger. But if your rest of your body is missing trains, it doesn't know that you have less trains than normal. It just tells you how many seats are taken by oxygen on your train, right? So anemic patients, sickle cell anemic patients, shock patients, all of those, this is a really poor indicator of accuracy of that SpO2. That makes sense? Okay? It's just like what's really cool, and we'll do it a little bit later, put an SpO2 on your finger and then put a tourniquet on your arm. It hangs out at 100%, even when your cap refills like 48 seconds. It's still like, you're good, right? And then after like an hour, it's like 95%. It doesn't have bled forever. Okay? Nail polish is my favorite. You get the girl that has the, clearly $400 nails, and you're like, sorry. That's just wipe that off with alcohol, right? Or you can be the nice person and put it on their earlobe, their toe, something like that. Like I tell all my EMT students, if you wear a ponytail, something like that, I can't get a seat collar on, but I have scissors for it. They're like, what? Just kidding. God, we use a knife instead. Blood glucose monitors, technically it's a procedure, not a vital sign, but would you agree this should be a procedure you should do on almost all of your patients? I agree too. Why is it not recommended for every patient? Why do you think that is? What does the textbook say? Why not everybody? What the reason is? Well, there's that side, which not what they're really thinking. That's a good point, though. Because you just increased your chance of a needle stick and a bloodborne pathogen exposure. That's it. You break their skin, which now their risk of infection, your risk of their blood, and you're using a needle. Now, how many of you, like I feel like if you can't operate one of them spring-loaded needle-safe things, you don't really belong in the event. Like you shouldn't have steak knives, you shouldn't have sporks, nothing that has a pointy end you should be allowed to touch. Right? Like if you can't work one of those things, like deserve a tack hammer to the forehead. Okay? If you've got one of these, great. If not, on the transport side, I don't like using my patients' glucometers. Because God forbid they don't have insurance and they have to pay out of pocket for the strips and these things. I don't want to be costing them money. Patients pay a lot of money for your service in most cases. Whether it's bonds and levies or taxes or whatever, use your stuff. They're going to get a bill most likely for your care, so you might as well let them get their money's worth. Make sense? And some of you are like, we don't bill people, we work for free.
Plus, you pour it out to use your own better than theirs.
Yeah, exactly. Yeah, you really can't. And just to eliminate any issues, we have this issue with the fire department that I work with, not work for. The bloody end does not go inside the machine. Okay? The other end goes in there, and that tells you. Okay? And the other one is don't yell when the blood glucose says 5 and then 4, and then that's not their glucose. It's counting down to tell you these are all those stories. I'm not making this crap up. Okay? Literally can't make this crap up. Tell me. When it says error, that's usually a battery problem, so don't freak out. It says error. Prepare the strip, so on. Usually they tell you blood glucose is normal ranges from 60 to 140. Right? Now, you'll get that patient, I think this even says coming up, I must have got rid of it. It says, anything over 160 or something is considered to be hyperglycemic. I'm out. Sure, by definition. But when you're a diabetic patient, the glucose comes back at 300, be like, what's your normal? You're like, 3, 310, 340, sometimes 400. Okay. So yes, it's hyperglycemic, but it doesn't mean it's abnormal. Don't freak out and start, activating all kinds of stuff for DKA and things along those lines. Okay? We We already kind of talked about GCS. On the end-tidal CO2 side, or the waveform side, utilizing those devices to confirm your tube placement is a good idea. That's what these look like. This esophageal detection device is old school. The idea is it's like a little turkey baster, right? You squeeze it, you stick it on the ET tube. If the ET tube was in the gut, your esophagus is flexible, so that pressure would suck the esophagus against the tube and the bulb would stay sucked together. If it's in the trachea, that bulb would just reinflate all on its own. It was a real quick way of confirming tube placement we don't use anymore. Capnography we talked about, capnometry we talked about, or end-tidal CO2. This we did use, and there are still agents that use them. This is that CO2 block, a little carbon piece of paper in it. When you squeeze the bag and let go, it should create a gold color on that piece of carbon paper where the purple is in this case. The downfall is it's only good for a couple of breaths. Once it's saturated with oxygen, that carbon paper is toast. So it was only good for an initial confirmation. Again, these two on the left are initial confirmation devices. These two on the right allow a continuous confirmation of your airway placement. Okay? All right, breath sounds, right? This one everyone should be good at and at least be, working to get better. But it's one of the things I started doing. Let's stop trying to tell you all these cool definition words, right? Like, I don't care if you can produce a rad word. I want to know what it sounds like. You tell me, what does it sound like? It sounds wet. It sounds rattly. It sounds gunky. Or I don't frickin' hear anything, right? I don't want you to produce a word. Those words are great. I think you should know the definitions of them. But stop. What happens is you get like words like rails and rhonchi confused, and they're different. So I don't want you telling me one thing, communicating the word and being wrong. So wet, dry, gunky, normal, whatever the case might be, right? Now, I love this picture right here, because in my opinion, this is the very best picture to remind you of the 5 things that are important when it comes to listening to lung sounds. First thing is, what position do you note that patient's in? No, not that side. You're right, but sitting, right? That's how you should be listening to lung sounds. Now, if they're unconscious, something like that, they're going to be laying flat. That's okay. But preferably sitting up. The next thing, right? You notice that the EMT is listening on bare skin. This is the one, not through coats, not through sweatshirts, not through base layers, not through that stuff. The next thing, right? Which side of the body is the EMT listening on? I wasn't thinking that specific. Back. Good job. Yep. That's the best place to listen. And you should listen to high, to middle, to low. Right? 6 places. And then you could argue, go to the front and listen to 6 more places. Okay? Know your stethoscope. I love EMTs that work that stethoscope out and listen and realize that they're listening on the wrong end. You got the dual-headed stethoscopes, they're looking, I can't hear anything. I always tell EMT students, put it in your ear and then flick the bell of the stethoscope. If it doesn't make you flinch, it's turned the wrong way. And they flip it and flick it and go, ow, see? Right? It hurts, doesn't it? Or I take the end and go, does this work? That works too. Oh my God. Perfect. Right? And then again, you shouldn't be pushing so hard on that stethoscope that you're smashing the diaphragm, right? It's got that plastic bubble. You don't have to push real hard, okay? So let's define wheezes. First off, is it an upper airway or a lower airway problem? Upper. You sure? Define upper. Above the... Yeah. So wheezes is a whistling sound that you hear down in your, that's way too low, bronchioles or trachea, which means it's a lower airway. Stridor is almost the same noise, only we hear it in the upper airway. Okay? So let's go back to this one. So wheezes, high-pitched whistling expirations, heard in asthma patients when airways are narrow, right? Crackles or rails. This is that bubbling sound. This is that wet sound. This is down in the airways. And then notice how it says fine crackling. When I say fine crackling, what do you perceive it's going to be?
Rice.
Maybe Rice Krispies, and really hard to hear, right? So this one is the one you're like, God, this doesn't sound right. It sounds kind of wet, but it's really quiet. Because it's way down in the alveoli. And what happens is when you inhale, those alveoli smack open. So you're getting that pop noise of all your alveoli, right? Now, the bronchi side, this is coarse, which means a little bit easier to hear, okay? Similar to wheezes, but it does not involve the alveoli. We're talking about thick secretions heard in the larger airways. This is a roll or a vibrating one, and it's mucus stuck on the large airways. It vibrates when you blow air by it, okay? And here in a second, I'll let you listen to it, okay? Questions on those four? Let's listen, shall we?
So it seems like Strider was the only upper airway.
Yeah, for the most part.
Breath sounds that you should be familiar with. Snoring, caused by partial obstruction of the upper airway, often caused by the tongue. Strider, a harsh, high-pitched sound heard on inspiration, is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration.
That's not wheeze.
Bronchi is a rattling sound heard in the larger airways caused by excessive mucus.
Get that rolling sound to it.
Rales are a bubbling sound heard in the smaller
Now,
airways.
see how you can get these two confused?
Commonly encountered with CHF and pulmonary edema.
See how similar those two are? One sounds wet and one sounds gunky to me. So that's why I don't want you to get caught up in, what does it, the difference, but more on the other side.
Welcome to another high yield anatomy.
Make sense? Questions?
Cool.